Now, another way to look at patient with predominant transaminitis. So we saw earlier that whenever a patient has predominant transaminitis, so I'm looking basically at patients with a R ratio more than 5. This is the category of patient that I'm looking at. So whenever a patient has predominant transaminitis, we can look at the degree of transaminitis to see what could be the possible liver injury that we are looking at. In addition, we can also look at the pattern of transaminitis elevation. So the degree of elevation means how much is it elevated. So we saw earlier, right, if it is going to be less than 200 chronic viral hepatitis, 200 to 600 could be all these acute viral hepatitis, and all the other rare causes could also cause transaminitis less than 600, like Wilson's, alpha-1 antitrypsin deficiency, hemochromatosis. But if it's more than 600, you're either looking at an acute viral hepatitis or toxin or ischemic hepatitis. Now, in addition to this degree of elevation, the pattern of elevation. So when I say pattern of elevation, what do I mean? So we have two transaminases, right? The alanine transaminase and the aspartate transaminase. So between these two, which one shows a dominant elevation, which one is going to be predominantly elevated? Based on that, we can categorize what is the likely liver disease that we are dealing with. So for instance, if the AST is going to be more than ALT, so if this patient has a SGOT predominant transaminitis, then we are looking at, so I remember this as ABC and HIT. So it could be alcohol-related liver disease, Budd-Chiari, specifically an acute Budd-Chiari, cirrhosis and congestive hepatopathy for C. So these are the three important ABCs for SGOT more than SGPT. So alcohol-related liver disease, Budd-Chiari, particularly acute, and cirrhosis and congestive hepatopathy. In addition, rarely you can have hepatic artery occlusion, ischemic hepatitis, and total parenteral nutrition, HIT. So, but remember the ABC, even if you forget the other three, it's fine. So, whenever SGOT is more than SGPT, alcohol, Budd-Chiari, acute, cirrhosis and congestive hepatopathy. Now, on the contrary, when the vice versa happens, when SGPT is going to be more than SGOT, everything else basically. So, you have your viral hepatitis, NAFLD, drugs, toxins, hemochromatosis, autoimmune, Wilson's, alpha-1 antitrypsin deficiency, veno-occlusive disease, even in sepsis, macrophage activation syndrome, acute fatty liver of pregnancy, HELP, in all of this. So basically in all these conditions, except for the ones that we discussed earlier, which is primarily alcohol-related liver disease, Budd-Chiari, and congestive hepatopathy and cirrhosis. Except for that, everything else, the SGPT is going to be elevated more than SGOT. So in these conditions particularly, your SGOT is going to be elevated more than SGPT. So it may be a good idea to remember just these conditions alone, and everything else put them under SGPT predominant transaminitis. Now we'll have to also understand that as I told you earlier, SGOT is not only produced by the liver, it is also produced by muscle, by brain, by kidneys, by the blood cells, white blood cells, red blood cells, lungs. Therefore, several non-hepatic disorders can cause increase in SGOT particularly, but basically increase in transaminases. So what are they? Muscle damage, rhabdomyolysis, thyroid disease, severe exercise, heat stroke, hemolysis, adrenal insufficiency. So all of this, so basically broadly, hemolysis, destruction in the blood cells, or myolysis, destruction of the muscle. It could be from myocardial infarction, from rhabdomyolysis, severe exercise, heat stroke. Basically anything causing severe muscle injury or lysis of the blood cells can cause elevation in transaminitis. So these are the non-hepatic causes which need to be kept in mind. So this is something that comes in very handy. So as I told you earlier, AST-ALT ratio. So if this is going to be high, if it is more than 2, an alcohol-related liver disease becomes very likely, and if it is more than 3, then the possibility becomes even higher. So an AST-ALT ratio of more than 2 makes an alcohol-related liver disease very likely. Similarly, AST-ALT ratio less than 1, that means your SGPT is more than SGOT. Now this is more common in patients with viral hepatitis and in NAFLD. And as they develop cirrhosis, even these patients, as they go on to develop cirrhosis, then you find that this ratio gradually becomes more than 1. But if it is more than 2 or more than 3, so higher the ratio, more likely it is to be alcohol-related liver disease as long as the ratio is above 2. Now, another way of looking at this elevation in ALT and AST. So, first we saw the degree of transaminitis. We looked at whether it is less than 5 times the upper limit of normal, 5 to 15 times, or more than 15 times the upper limit of normal, and saw which are the liver disorders which could present in with that degree of transaminitis. Second, what did we do? We looked at the pattern of transaminitis abnormalities. So, some diseases predominantly presented with a SGOT increase, particularly alcohol-related liver disease, Budd-Chiari, congestive, and cirrhosis. So, for them, the AST, ALT, the ratio, that is going to be more than 2. So, whenever it's more than 2, think of an alcohol-related liver disease. So, certain other conditions can present with the SGPT predominant elevation like NAFLD and chronic viral hepatitis, where the AST, ALT ratio is going to be less than 1. So, the other way of looking at transaminitis is by looking at the comorbidities or by looking at the host and the kind of host that we are treating. So, if there is an elevation in AST and ALT, the first thing that we do is to look at their pre-existing HbSAg and HCV status, because it could be chronic viral hepatitis. Now, if a patient with a metabolic syndrome has a mild elevation in AST and ALT, then probably we are looking at a NAFLD or we are looking at a fatty liver. Now, if a patient has history of alcohol consumption and comes in with elevation in AST and ALT, then you're looking at an alcohol-related liver disease, and the first thing that you need to do is to advise alcohol cessation. Another thing, once you've ruled out chronic viral markers, you've looked at the HbSAg, HCV status, the patient is not obese, no features of metabolic syndrome, no history of alcohol consumption, then you will review drug history. Often, drugs are very important causes of slight elevations in transaminases. So, it could be a drug-induced liver injury. And finally, once you ruled out all of this, if the patient is negative for hepatitis B and C, patient has no features of metabolic syndrome, no history of alcohol consumption, drug history has been reviewed, and this elevation in AST and ALT has been fairly recent because we've documented a normal baseline AST and ALT, that is when you will consider acute hepatitis and do the viral markers. So, if these are the most common causes of transaminitis in the routine outpatient department. So, we have a chronic viral hepatitis, we have non-alcohol related fatty liver disease, then we have alcohol related liver disease, drug-induced liver disease, and you have acute viral hepatitis. Now, if these conditions have been ruled out, then you will have to think of the rarer causes, which include hemochromatosis when you will be doing the iron studies. If the transferrin saturation is more than 45% with an elevated ferritin, then this becomes more likely. It could be Wilson's disease when you will be looking at the eye for the KF ring that I just showed you a little while back. You will be looking at the serum ceruloplasmin, which is going to be low, and the 24-hour urine copper is going to be high. You may also consider autoimmune hepatitis if the patient has positive ANA, further on supported by antibody against the smooth muscle antigen, and asthma. And finally, very rarely you can do an alpha-1 antitrypsin levels, and if that is low, that tells you that this patient has alpha-1 antitrypsin deficiency. So, these are the most common causes. Once they have been ruled out, you can consider other rarer causes like hemochromatosis, Wilson's, autoimmune hepatitis, and alpha-1 antitrypsin deficiency. So, at the end of this, after doing all these tests, even then you do not have any answer, then all roads lead to liver biopsy. So, even at that point, you've done all of this, you worked up your patient with viral markers, no evidence of metabolic syndrome, no alcohol consumption at all, no use of any hepatotoxic drugs in the recent past, you've done your iron studies, copper studies, autoimmune panel, alpha-1 antitrypsin level, and still you're lost, that's when the liver biopsy is going to be helpful. Now, we looked at in great detail about how we would approach a patient with transaminitis. We looked at how we would approach based on the degree of transaminitis, based on the pattern of transaminitis, if SGPT was more elevated or if SGOT was more elevated. And finally, we looked at how to interpret transaminitis abnormalities based on the host that we are treating. So now it's time to look at how we approach a patient with predominant elevation in the alkaline phosphatase. Now, as I said earlier, any and every alkaline phosphatase elevation does not always point towards the liver, because there are three important sources: the hepatobiliary, bone and the placenta. So whenever you have a patient with, so you have hepatobiliary, bone and the placenta. So whenever you have a patient with elevated alkaline phosphatase, GGT is the first thing that needs to be done, and if GGT is high, it points towards a hepatobiliary source of alkaline phosphatase. The second thing that we need to do is to see the associations. So what are the associations? When I say associations, we'll have to see whether this is going to be associated with a normal AST, ALT in bilirubin, or whether it is going to be associated with a high transaminase level and bilirubin level. Now, if there is an isolated, if AST, ALT and bilirubins are normal, this is referred to as an isolated alkaline phosphatase elevation. So, in that case, as I mentioned earlier, GGT is the first thing that we do to rule out a bone cause of elevation in alkaline phosphatase, which is very common. Even conditions like vitamin D deficiency, which is so prevalent, can produce a slight elevation in alkaline phosphatase. So, if the GGT is normal, then we are going to think of a non-hepatic cause. But if it is high, then we are going to think of causes like early cholestasis. That is why the bilirubins have not gone up yet. So, in early cholestasis, only the alkaline phosphatase will be elevated. Certain drugs can cause isolated alkaline phosphatase elevation, primary biliary cirrhosis, primary sclerosing cholangitis, hepatic infiltrative disorders. So, any hepatic infiltration like amyloid or tuberculosis, and finally patients with HIV cholangiopathy. So these are all the causes, the hepatic causes of isolated elevation in the alkaline phosphatase. So if the GGT is normal, then it is a non-hepatic cause of alkaline phosphatase elevation. So as I mentioned earlier, bone is a very important source. So could be bone malignancy, both primary and secondary. Could be a bone disease with high turnover like Paget's, could be osteomalacia, vitamin D deficiency, hyperparathyroidism, then hyperthyroidism, chronic kidney disease. So, and finally, even in patients with infections, diabetes and congestive heart failure can have elevation in alkaline phosphatase. So, remember that I mentioned earlier that small bowel is also an important source of alkaline phosphatase. So, in patients with O blood group and B blood group, following a fatty meal, there is an increase in the alkaline phosphatase from the small intestine, which can also contribute to a slight increase in the alkaline phosphatase. So, this is how you would approach an isolated elevation in alkaline phosphatase. So, suppose if all the other liver function tests are normal, then you need to do GGT and just rely on it. If your GGT is high, you're looking at a hepatic hepatobiliary cause. So, you're going to need to follow this up with imaging, and you need to rule out drugs, because early cholestasis, hepatic infiltration and drugs are important causes of isolated elevation in alkaline phosphatase. If your GGT is normal, then it could be anything from a bone mets to a hyperthyroidism to diabetes mellitus to CKD. Now, if your elevation in alkaline phosphatase is going to be associated with other liver function test abnormalities, then this is pretty straightforward. One, it could be biliary obstruction, so we need to image the patient. Two, it could be an infiltration in the liver like sarcoid, TB, amyloid, lymphoma. Three, it could be viral hepatitis, it could be cirrhosis, could be alcohol-related liver disease, intrahepatic cholestasis of pregnancy, total parenteral nutrition, and hemophagolymphohistiocytic syndrome. These are all the different causes of hepatobiliary increase in alkaline phosphatase. So, whenever you have a patient with alkaline phosphatase elevation, if it is, the first thing to look at is the rest of the LFT. Is the LFT normal or not? If the LFT is normal, that is when your GGT will be helpful. If your GGT is abnormal, it is still going to be a hepatobiliary cause. If your GGT is going to be normal, you are looking at a bone or a systemic cause. Suppose your LFT itself is abnormal. So, the elevation in the alkaline phosphatase, if the LFT itself is abnormal. So, this elevation in the alkaline phosphatase is associated with abnormalities in rest of the LFT, then it is pretty straightforward. You are looking at either a biliary obstruction or a hepatic infiltration, two very common causes of significant elevation in the alkaline phosphatase. In addition, could be any other liver disease like viral hepatitis or alcohol-related liver disease or cirrhosis. So, in addition to this, with the transaminitis, the degree of alkaline phosphatase elevation also tells us roughly the kind of liver problem that we are going to be dealing with. So, for instance here, if the alkaline phosphatase is elevated but it is less than 4 times the upper limit of normal, then you are looking at a liver disease, or it could be a non-hepatic cause like a bone metastasis or hyperthyroidism, hyperparathyroidism, vitamin D deficiency and so on. Suppose it is more than 4 times the upper limit of normal, remember that it is almost always cholestasis. But this does not help us to differentiate between an intrahepatic and an extrahepatic cholestasis. And finally, sometimes alkaline phosphatase can be abnormally low, and that's when you'll think of Wilson's, zinc deficiency, hypothyroidism or pernicious anemia. So, the degree of elevation in alkaline phosphatase, the important thing to remember is that if it is more than 4 times the upper limit of normal, almost always cholestasis, but we don't know whether it is intrahepatic or extrahepatic. For that, we definitely need an ultrasound or any imaging. So, having looked at how to approach alkaline phosphatase, let's just quickly look at what is the definition of fulminant or an acute hepatic failure. Now, rapid onset of liver injury with severe impairment in synthetic function of the liver as evidenced both by coagulopathy and hepatic encephalopathy in a patient with no obvious pre-existing liver disease is when we would refer to the patient as fulminant hepatic failure or acute hepatic failure. So, the important thing to remember is that in a patient without any obvious pre-existing liver disease, in such a patient, a rapid onset liver injury with a severe synthetic function impairment as evidenced by coagulopathy and hepatic encephalopathy. If you have this syndrome, then this patient has an acute hepatic failure. Now, having looked at transaminases and alkaline phosphatase in detail, now we are going to learn a little bit about bilirubin. Look at hyperbilirubinemias and learn about jaundice. Now, what is bilirubin? Bilirubin is the end product of heme degradation. There are 2 kinds of bilirubin. We have the unconjugated bilirubin, which is bound to the albumin and hence is not water soluble, not excreted in the urine. So, unconjugated is insoluble. And then you have the conjugated bilirubin. The conjugated bilirubin is the water soluble bilirubin, therefore is freely excreted in the urine. Now, let's look a little at the bilirubin formation. How is this bilirubin formed? Now, bilirubin is produced in the reticuloendothelial cells in the liver and spleen, and it is produced at a rate of about 4 mg per kg per day. 85% of the bilirubin that is produced comes from the heme, from the old RBCs. Another about 15% comes from the myoglobin and from the cytochromes. Now, the first step is heme oxygenase acts on the alpha chains and it opens the porphyrin ring. And what are the end products of this step? This step results in biliverdin, carbon monoxide and iron. Now, this biliverdin is going to be acted upon by biliverdin reductase, and biliverdin reductase converts the biliverdin into bilirubin. Now, bilirubin is not soluble. Therefore, what happens is there is a non-covalent binding to albumin which occurs, through which it finally is able to be transported by blood, through blood to the liver. So, these are the important steps that need to be remembered. So, one, heme oxygenase, it opens up the porphyrin ring and it gives you biliverdin, carbon monoxide and iron, and biliverdin reductase acts on bilirubin, converts biliverdin into bilirubin. But bilirubin cannot be transported directly by bloodstream. Therefore, it is non-covalently bound to albumin. And remember, this is non-covalently bound to albumin and then transferred via blood to the liver. So, what happens in the liver? Now, in the liver, hepatocellular uptake takes place. There is a transporter about which a lot of research is going on and we still do not have much clarity on. So, hepatocellular uptake takes place and then there is an intracellular binding within the hepatocytes, and this is where something called ligandin plays a very important role. And once this binding occurs, what happens is the bilirubin is subjected to the activity of this enzyme called UDP glucuronide transferase. And UDP glucuronide transferase is very important for conjugation of bilirubin. Now, bilirubin is converted into mono and diglucuronides. Bilirubin monoglucuronide and bilirubin diglucuronide. Now, these conjugated forms of bilirubin are very important because this is the only form in which they will be excreted across the bile canalicular membrane into bile. So, earlier we used to think that conjugation was rate limiting step in the synthesis of bilirubin and the excretion of bilirubin. But now we've come to understand that the excretion across the biliary canalicular membrane into the bile, this is the most important rate limiting step in the bilirubin metabolism. And finally, you have excretion into bile. Now, excretion into bile is an ATP dependent process. This is mediated by a protein called MRP2. What is MRP2? It is a multi-drug resistance associated protein 2. Now, in addition, there is another protein called multi-drug resistance protein 3, which facilitates portal circulation. So, what happens is the bilirubin is returned and finally hepatic uptake takes place from these sinusoids through these transporters OAT, P2B1 and 3. So, this is in a sense a very quick rapid version of the bilirubin metabolism. So, first you have heme oxygenase which opens up the porphyrin ring and you get biliverdin. Now, biliverdin reductase acts on the biliverdin and converts it into bilirubin. And this bilirubin, which is actually being produced in the reticuloendothelial cells in the spleen and liver, will have to be transported via blood to the liver. So, this bilirubin is going to be non-covalently bound to albumin, which then carries it all the way to the liver. In the liver, hepatocellular uptake takes place through an unidentified transporter, and inside the hepatocyte, there is an intracellular binding. This happens through ligandin. And finally, it is subjected to the action of this enzyme called UDP glucuronide transferase, which is an important enzyme for conjugation. So, bilirubin is converted into bilirubin mono and diglucuronide, and this is very important because this is the only way in which it will be excreted through the bile canalicular membrane into the bile itself, and this is the rate limiting step. And biliary excretion per se is a ATP dependent process which is mediated by MRP2, multi-drug resistance associated protein 2. Now, what happens to the bilirubin once it is excreted in the bile? So, what happens? It reaches the gut. So, it is converted by the bacteria into water-soluble urobilinogen. So, the conjugated bilirubin, remember, it is the conjugated bilirubin that reaches the gut and that is converted by the bacteria into urobilinogen. And then what happens? It is taken up by the enterohepatic circulation, this urobilinogen, and parts of it is going to be excreted by the kidneys, and that's how we are able to see this urine urobilinogen. And kidneys usually excrete conjugated bilirubin because conjugated bilirubin is water soluble. So, urine may contain both conjugated bilirubin and urobilinogen. Now, normal parameters as far as bilirubin is concerned, what is a normal level of bilirubin? 1 to 1.5 milligram per deciliter is the normal level of bilirubin. So, remember that under normal circumstances, 100% of the bilirubin is actually unconjugated. About 3% or even lesser than that is only going to be made up of the conjugated bilirubin. And even in that small fraction, it is all largely going to be monoglucuronide, bilirubin monoglucuronide. So, generally, whenever you have a patient with hepatobiliary disease and with jaundice, remember, because of this normal process, the monoglucuronides at any instance are going to be much more higher than the diglucuronides. So, in a patient with a conjugated hyperbilirubinemia, almost always the monoglucuronides are going to be higher than diglucuronides. Another important thing which we need to know is the delta bilirubin. What is this delta bilirubin? Now, we know that the unconjugated bilirubin, right, the bilirubin before the conjugation process, that is what binds to the albumin, and that too it binds to the albumin non-covalently, so that it gets transported through the blood to the liver, right. But what is delta bilirubin? Delta bilirubin is basically the conjugated bilirubin which is going to be covalently bound to albumin. So, delta has two important C's. So, here this is the conjugated bilirubin that is bound to albumin. And how is it bound? It is not bound in a non-covalent manner. This is bound in a covalent manner. So that is very important and should not be confused with the earlier albumin bound transport of the unconjugated bilirubin. So delta bilirubin is the conjugated bilirubin that is covalently bound to the albumin. And importantly, this is, it's very important to remember this, because whenever patients have very high levels of conjugated bilirubin, particularly in cholestatic disease and hepatobiliary diseases, then what happens? A chunk of this conjugated bilirubin gets converted into delta bilirubin. Therefore, it takes a longer time for this delta bilirubin to be excreted, right? Because it's bound to albumin, it's not going to be freely excreted in the urine, and therefore the recovery, the time taken for the bilirubin levels to decrease is going to be slower because of this reason. And for the same reason, there is going to be lesser bilirubinuria in patients with conjugated hyperbilirubinemia. So the important understanding from this concept of delta bilirubin is that in patients with conjugated hyperbilirubinemia, usually the urine bilirubin is going to be high. But sometimes it can be false negative. Whenever it's false negative, remember who is the culprit? This delta bilirubin is the culprit. You understood this concept? Because the albumin, whenever bilirubin binds to albumin, it will not be freely excreted into the urine. Similarly, it is a conjugated bilirubin that is water soluble and hence will be freely excreted in the urine because it is water soluble. So, whenever a patient has conjugated hyperbilirubinemia, ideally the urine bilirubin should be positive. Or the caveat to this is, whenever a patient has urine bilirubin which is high, that means this is conjugated bilirubin and therefore we are dealing with conjugated hyperbilirubinemia. But sometimes it can be false negative, which means even in patients with conjugated hyperbilirubinemia, urine bilirubin may be negative, in which case you will have to think about this delta bilirubin. Yeah. So, unconjugated bilirubin, as I said, under normal circumstances makes up for about 100% of the total bilirubin. So, in that situation, how will you classify whether a patient has an unconjugated hyperbilirubinemia or a conjugated hyperbilirubinemia? So, you will look at the direct fraction. If your direct fraction is going to be less than 15%, so this is basically in patients with hyperbilirubinemia. When you have the direct bilirubin less than 15% of the total bilirubin, you are looking at indirect or unconjugated hyperbilirubinemia. On the contrary, if the direct fraction makes up for more than 15% of the total bilirubin, you are looking at conjugated hyperbilirubinemia, conjugated or direct hyperbilirubinemia. And this is almost always associated with bilirubinuria. The only exception, false negative, remember, is because of the delta bilirubin. So, how do we approach a patient with hyperbilirubinemia? So, as I said earlier, the first thing to do would be to see whether it is a direct hyperbilirubinemia or whether it is an indirect hyperbilirubinemia. If it is a direct hyperbilirubinemia, the direct fraction is going to be more than 15%. If it is an indirect hyperbilirubinemia, again you are going to only be looking at the direct fraction. The direct fraction, if it is going to be less than 15%, then it is indirect hyperbilirubinemia. So, let us first look at indirect hyperbilirubinemia. How do you approach patients with indirect hyperbilirubinemia? Now, whenever a patient has increase in the indirect bilirubin or the conjugated bilirubin, so there is a problem in one of the steps before even conjugation takes place, right? So, could be that there is excessive production of the bilirubin that the conjugating apparatus is not even able to handle, or could be that there is a decreased clearance of the unconjugated bilirubin. So, basically there is a problem in the conjugating system or hereditary defects in conjugation. So, if there is a problem with the conjugation apparatus, then what happens? A lot of unconjugated bilirubin is just staying put without it going through the conjugation process. So, these three primarily are important causes of indirect hyperbilirubinemia. Could be an increase in the production, could be a decrease in the clearance, and could be impairment in conjugation. So, increase in production could result from hemolysis. So, as I mentioned earlier, 85% of the bilirubin actually comes from the old RBCs. So, if there is an increase in the RBC destruction, then suddenly a lot of heme is available for conversion into bilirubin. So, all the hemolytic anemias like G6PD deficiency, hereditary spherocytosis, Other causes of acquired hemolysis like hemolytic uremic syndrome, paroxysmal nocturnal hemoglobinuria, malaria, all of these can produce indirect hyperbilirubinemia secondary to hemolysis. Second is ineffective erythropoiesis. So generally, during the maturation of the RBC, small amounts of hemoglobin are actually extruded. Now, in this process may be amplified in patients with ineffective erythropoiesis, like for instance in patients with thalassemia or in patients with megaloblastic anemia secondary to B12 deficiency. So, even in them, indirect hyperbilirubinemia may be commonly seen. And finally, in patients with extravascular RBC collection, either from a large tissue infarction or from a large hematoma, such patients again can have hemolytic jaundice or indirect hyperbilirubinemia. Now, remember that whenever a patient has indirect hyperbilirubinemia secondary to one of these causes, as long as the liver is normal, usually the degree of bilirubin elevation is very mild. It is very rarely that you find the bilirubin level above 5 mg per deciliter. Often it is less than 4 to 5 mg per deciliter. So, in a patient with much higher isolated indirect hyperbilirubinemia, that means the liver has been compromised. As long as the liver is intact, usually in patients with isolated indirect hyperbilirubinemia, their levels, whenever there is either a hemolytic process or ineffective erythropoiesis, the level of bilirubin is usually less than 4 to 5 mg per deciliter. Now, what are the causes for decreased clearance? Decreased clearance is basically decreased clearance of the unconjugated bilirubin from the blood. So, what does that mean? That means there is a problem in the hepatic uptake. Now, this can happen with certain drugs like rifampicin or novobiocin, and it has also been seen with patients with Gilbert syndrome. Or there can be decreased conjugation. So, decreased conjugation can be seen in physiological neonatal jaundice. Certain drugs like atazanavir and chloramphenicol. Atazanavir can reduce the activity of the conjugating enzyme. Even breast milk jaundice can cause decreased conjugation because of the fatty acids in the breast milk, which exert an inhibitory effect on the enzymes involved in conjugation. So, all of this can result in indirect hyperbilirubinemia. And finally, you have a unique syndrome called the Lucey-Driscoll syndrome, where the maternal serum is actually going to have inhibitors to the UGT1A1, which is the conjugating enzyme. And therefore, patients can have a neonatal jaundice, transient familial neonatal jaundice. So, these are the different causes of decreased clearance from the blood, which can result in indirect hyperbilirubinemia. So, particularly drugs like rifampicin, atazanavir needs to be remembered. All the other are neonatal related causes. And then finally, you have hereditary defects in conjugation. So, under this head, we have three important syndromes, the Crigler-Najjar syndrome 1 and 2, and then you have the Gilbert syndrome. So, before we look at the syndromes, I would like you all to remember that whenever you have a patient with an indirect hyperbilirubinemia, you will think of one, hemolysis. So, which could be in the form of a hemolytic anemia, or there could be a acquired hemolysis like malaria. 2. Any causes of ineffective erythropoiesis, which is what is seen in conditions like thalassemia or other hemoglobinopathies. So, erythropoiesis. And 3, very importantly, you will look at the drugs like atazanavir, rifampicin, novobiocin, chloramphenicol. If you've ruled out all of this, then it could be one of the genetic syndromes. So, broadly speaking, these 4 are the important causes of an indirect hyperbilirubinemia.